So hello to everyone and welcome to this ground round. My name is Neofytos and we will go over myopia control and review the current interventions. I will start with few cases. First is a 12-year-old boy with a paternal history of high myopia, presented first at our clinic in 2021 with a cycloplegic refraction of -4 in the right eye and -4.25 in the left eye. We discussed early intervention with myopic control at this stage, but the child seemed very reluctant and against the idea. So the patient did not return for follow-up until 2023. He stated that his vision had worsened and his refraction at that time was -4.75 in the right eye and in the left eye -5. So we discussed again myopic progression and the patient agreed to start treatment with atropine 0.01%. And on the last examination in 2024, 1 year since atropine initiation, his refraction was stable. This is another patient, a 13-year-old boy who started atropine 0.01%, and the refraction at the time was -3.25 in the right eye, -2.5 in the left eye. And on his last examination, his spherical refraction increased, which indicated that atropine did not seem to slow the myopic progression in this patient. This is another patient, 10-year-old girl who started atropine of 0.05% since 2022. At that time, her refraction was -4 in the right eye, -4.5 in the left eye, and on her last examination 2 years later, her spherical refraction only increased by 1/4 of diopter, which is practically stable. And last case, a 12-year-old boy who, when presented with different options for treatment of myopic control, he decided to use the MySight glasses. At that time, his refraction was -2.5 in both eyes, which remained stable at 1 year follow-up, showing that the glasses were working. On his last examination, around 9 months later, his spherical refraction increased to -3.25 in both eyes. And this brings us to today's topic, which is myopia control. This issue is not confined to pediatric ophthalmologists only. It impacts all ophthalmologists daily. The numbers are rising every year, and it seems that myopia is outpacing our efforts to slow it down. Yet, there remains a lack of clear protocols and unbiased information. So today, we aim to present a review of the current treatment options. There are two theories regarding the progression of myopia. One theory hypothesizes that hyperopic retinal blur caused by accommodation during near work accelerates axial elongation. As we see in the diagram, the peripheral retina is more hyperopic, and it is reported that this hyperopic defocus may cause excessive eye growth and myopia. A second theory proposes that mechanical tension created by the ciliary body restricts equatorial ocular expansion, thereby accelerating axial elongation. Currently, there is no consensus of myopia control, but some interventions have shown variable effectiveness in slowing the progression, and these fall into 4 main categories: environmental and behavioral, pharmacological and optical, and new approaches. So we will touch base on their effectiveness, their safety, and their cost. Looking first at the environmental interventions, evidence suggests that spending at least 40 minutes per day outdoors and exposure to sunlight offers protection against myopia onset and slows down axial elongation. And as Eindhoven suggests, increased screen time from electronic device use is linked to myopia, and consequently, strategies to reduce prolonged near work are gaining attention. So these interventions come at no cost with a good safety profile, therefore are considered good recommendations. However, after myopia begins, it is unclear whether this intervention helps at all. Moving to optical interventions, orthokeratology involves wearing special contact lenses overnight to temporarily reshape the cornea during sleep. Other optical solutions include soft bifocals or multifocal soft contact lenses, which have been proven not to be very effective. Therefore, I won't elaborate. These two options, the ortho-K and the soft contact lenses, pose a risk of infection and an issue of cost, and therefore they are less commonly used. Further, special lenses have emerged that work through two main mechanisms, either the peripheral myopic defocus or by reducing the contrast signaling in the retina. The DIMS lenses from Hoya, the MioVision from Zeiss, and the SMC lenses from Shamir Company in Israel, they work based on the concept of peripheral defocus. These lenses include a central optical zone for correcting refractive error and multiple segments with constant myopic defocus around the central zone. This enables a clear central vision and simultaneous myopic defocus by aligning the peripheral light rays on the retina. The DIMS lenses were tested on children, and it was discovered that those who used these lenses for 2 years had an increase in myopia of only minus 0.3 diopters, compared to children who wore regular myopic spectacles and had an increase of almost 1 diopter. The next mechanism, dot lenses from CooperVision, was designed based on the hypothesis that reduced contrast signaling in the retina may slow myopic progression. The 12-month results published in 2022 showed a significant mean difference in spherical equivalent and axial elongation progression for the dot versus the control group. So all of these lenses are currently available. And if one mechanism does not work, then we can theoretically try the other. So compared to contact lenses, spectacles have the advantage of being infection-free and have an effective mechanism. However, they are costly and not aesthetically pleasing. Additionally, some patients find the peripheral blurry vision disturbing, and there is a lack of long-term data regarding their effectiveness. Moving on, the most common strategy used currently is the pharmacologically with atropine drops. The exact mechanism by which atropine works is not fully understood, but several theories exist, either by blocking of muscarinic receptors in the sclera, by increasing the dopamine release in the retina, and by increasing the choroidal thickening, all of which contribute to reduce eye elongation. The success of atropine is mainly based on two big studies from Singapore, the ATOM-1 and ATOM-2. Very briefly, the ATOM-1 study included 400 Chinese children who received either 1% atropine or placebo eye drops once nightly. And at 2 years, the mean progression of myopia in the placebo-treated eyes was significantly higher than the atropine-treated eyes. Therefore, they draw the conclusion that 1% atropine was effective in slowing the myopic progression. Then in 2006, the same group of researchers and similar patient characteristics proceeded to the ATOM-2 study, which compared 0.01%, 0.1%, and 0.5% of atropine, followed by a washout period of 1 year, and then a restart treatment for 2 years more, only with the 0.01%. At the end of phase 3, switching to 0.01% had even better efficacy than the other two dosages. So they concluded that atropine 0.01% retains comparable efficacy in controlling myopic progression and has minimal side effects when compared to 0.5%. Next, the LAMP study also provided a crucial milestone in today's use of low atropine use. The patients randomly received low-dose atropine concentrations, and they concluded that all doses reduced myopia progression along a concentration-dependent response, with 0.05% dosage being the most effective. The evidence for the efficacy of low-dose atropine eye drops originates mostly from data in East Asians. But what about non-Asian patients? And these meta-analyses analyzed the effectiveness and safety of 0.01 and 0.5% atropine eye drops from 9 studies conducted mainly in Europe, and a follow-up period from 1 to 5 years. The conclusion was that 0.01% atropine eye drops were effective in controlling myopic progression in non-Asian regions, and the 0.01% dose led to fewer side effects than 0.5%. Therefore, it has been observed that low-dose atropine is effective and safe in slowing down the progression of myopia in all ethnicities. More recent literature, though, such as this one from the United States, questions atropine's effectiveness by asking, do low-dose atropine 0.101% eye drops delivered nightly over 2 years slow the progression of myopia? And they compared 0.01% atropine with a placebo and concluded that 0.01% atropine eye drops didn't slow myopic progression or axial elongation of school-age children with low to moderate myopia. So we have seen mostly favorable and some conflicting results in the short term from 0 to 5 years. And what about beyond this period, after 10 to 20 years? Is atropine use still effective? This recent study from Singapore, the ATLAS study, addressed this question. What long-term outcomes were noted in adulthood among individuals receiving atropine during childhood for myopia? And if you think on it, the whole purpose of treating myopia during childhood is to prevent myopic complications in adulthood. And basically, this is the same group of researchers who published the findings of ATOM 1 and 2 studies. So the study included participants from the original ATOM 1 and ATOM 2 studies, who are now evaluated almost 20 years and 10 years respectively. Starting from the ATOM 1 group, 20 years after atropine cessation, when comparing the spherical equivalent, the axial length between the treated and the control groups, no significant differences were found. All groups exhibited progression in myopic refraction error and axial elongation after the final trial visit, which occurred 20 years ago. In the ATOM 2 group of patients, 3 groups were administered different atropine doses and did not display any significant differences in terms of spherical equivalent or axial elongation. So the final conclusion of the study is that short-term topical atropine is not associated with differences in final refractive errors are 10 or 20 years later. In conclusion, atropine is considered affordable and safe, even for long-term use, with dose-dependent side effects. Its effectiveness also depends on the dose and varies with ethnicity, and there are uncertainties about its long-term effects. One disadvantage is the rebound effect, which is also dose-dependent. Shall we stop more gradually? Is it significant to continue forever, or combine it with other interventions? And last, it is perceived as invasive, and the parents need to fight with their kids to use drops every night. So, is this worth it in the end? New approaches exist in the last intervention group, where red light therapy has recently been introduced to control myopia by increasing the choroidal perfusion. It is hypothesized that reducing choroidal blood flow can lead to scleral hypoxia, inducing a transformation of scleral fibroblast into myofibroblast, and ultimately weakening the scleral framework, resulting in axial elongation. Therefore, by increasing choroidal blood flow through red light therapy, may help to reserve the potential consequences of reduced choroidal perfusion. And so far, very few groups have published results, only from China, and Zhang and Xiong showed efficacy and effective results of axial elongation reduction at 12 and 24-month follow-up visits for the group undergoing red light treatment. However, caution is advised regarding its safety, as this 12-year-old girl reported by Liu et al. Experienced bilateral vision loss following red light therapy in both eyes. The OCT revealed disruptions in the foveal ellipsoid zone with partial recovery 3 months later. And despite the limited data available, red light treatment for myopia control is already commercially available in China, and it is gaining momentum in Australia, New Zealand, Japan, and Europe. So in summary, environmental behavior is evidence-based, cost-effective, and beneficial for pre-myopes and for general health and well-being. Myopia control spectacles are popular due to their safety and effectiveness. They are straightforward and the simplest solution, but further validation for long-term effectiveness in the real world is necessary. Contact lenses are gaining popularity worldwide, but we have concerns about the associated risks. And consideration of cost is essential, especially in families with multiple children. The effectiveness of low-dose atropine eye drops has mainly been studied in East Asians, and its impact on different ethnic groups is still debated. There are still unanswered questions about the starting dose, tapering, stopping, and long-term effects of this treatment. Some doctors recommend using only 0.05% of atropine, but we believe that 0.01% of treatment has benefits. It can be administered twice a day and has fewer side effects compared to 0.05. And in the end, if 0.01% of atropine does not work, we can consider increasing the dosage to 0.05%. There are almost no comparative studies between the different therapeutic categories, so it is challenging to know which one is better. However, we can consider combining treatment with atropine and glasses because they work by different mechanisms. So we believe that the key to managing myopia in children is openly communicating with families and personalizing our approach. This field is continuously evolving, and while we strive to provide answers, there are still uncertainties. During clinic visits, discussing habits and possible treatment with the parents is essential. Established research supports that spending at least 2 hours outdoors daily can help prevent myopia. And despite the wealth of information available, creating an evidence-based strategy for myopia controls remains challenging. So, what should we do next? What do you think about? Thank you very much for listening.